Welcome to This Week in Ophthalmology. This week, we're covering 10 notable papers spanning glaucoma risk stratification, retinal imaging and pharmacotherapy, and pediatric and anterior segment practice, including 2 randomized trials that may change what you offer in clinic tomorrow. Let's dive in. Let's start with glaucoma, where 2 papers from the American Journal of Ophthalmology tackle the same uncomfortable question. How do we know a pressure that looks fine in the office actually is fine? In a prospective cohort of 67 glaucomatous eyes, Malik and Medeiros used a standardized water drinking test as an intraocular pressure stress test, then tracked visual field mean deviation and optical coherence tomography retinal nerve fiber layer thinning over about 2 years. Among the 59 eyes whose office pressure sat within their severity-specific target, 37% of those eyes still spiked above 21 millimeters of mercury on stress testing, and those eyes lost field at roughly 2/3 of a decibel per year, while the rest were, on average, stable. Even more striking, of the 13 eyes classified as fast progressors, only about a quarter would have looked out of target on office tonometry, whereas more than 3/4 spiked on the water drinking test. That association held after adjusting for office pressure, which is the key point. This is complementary prognostic information, not a restatement of what your Goldman already told you. It is a small single cohort study and not a trial of treatment intensification. But for the patient who keeps progressing on paper-perfect pressures, a stress test is cheap and may explain the discrepancy. Alongside that, Lee, Morales, and Caprioli report long-term outcomes of selective laser trabeculoplasty in 500 eyes, followed for nearly a decade. Median time to failure was 4.6 years after initial treatment, but only 2.7 years after repeat treatment, and failure came sooner in eyes with prior glaucoma surgery, moderate to advanced disease, asthma, or lower laser energy. Interestingly, higher energy intensity predicted better pressure survival, yet was also associated with greater visual field progression at 5 years, alongside higher pre-laser medication burden and thinner corneas, a tension the authors flag rather than resolve. Practically, counsel patients that a repeat laser buys roughly half the durability of the first, and monitor advanced eyes more closely rather than assuming the laser has bought you time. Moving to the retina, 3 papers address how we predict and how we treat macular disease. In ophthalmology, Matar and colleagues analyzed 502 eyes with intermediate age-related macular degeneration using machine learning-enhanced layer segmentation with certified reader correction, asking which baseline optical coherence tomography features predicted 2-year progression to atrophy. Eyes that converted had greater ellipsoid zone attenuation, thinner ellipsoid zone to retinal pigment epithelium and outer nuclear layer measurements, higher drusen volume, and more hyperreflective foci. A random forest model using all baseline features reached an area under the curve of 0.85, with ellipsoid zone integrity and hyperreflective foci count the most influential predictors. This is not yet a clinic tool, but it tells you where to look on the scans you already have. Photoreceptor layer thinning without frank retinal pigment epithelium loss is a warning sign, and these metrics are likely to define enrollment in prevention trials. In JAMA Ophthalmology, Chong and colleagues followed 205 eyes across the pachychoroid spectrum, prospectively for 2 years. The reassuring headline is that progression to a worse phenotype occurred in only about 7% of eyes, with no meaningful change in visual acuity or choroidal thickness overall. Neovascularization developed in just 7 eyes, and every one of those had shallow, irregular retinal pigment epithelium elevation at baseline. That single imaging feature, if confirmed, is the one worth documenting when you decide follow-up intervals for pachychoroid pigment epitheliopathy or central serous chorioretinopathy. And on treatment, Ophthalmology Retina reports 48-week results from the Phase 3b/4 Salween trial of faricimab in 135 treatment-naive Asian patients with polypoidal choroidal vasculopathy. On a treat and extend regimen after loading, mean visual acuity gained about 9 letters, central subfield thickness fell by roughly 127 microns, and the proportion of patients free of subretinal or intraretinal fluid rose from about 14% at baseline to 76%. Among eyes with reading center confirmed lesions, About 61% achieved complete polypoidal lesion regression, and more than 80% of patients were on intervals of 12 weeks or longer, with over half assigned to 20-week dosing. Remember, this is single-arm and open label, so there is no comparator. But for a phenotype long treated with combination photodynamic therapy, durable extension on dual ANGIOP-OIETIN2 and vascular endothelial growth factor A inhibition is clinically meaningful. Now to pediatric and anterior segment care, where the most immediately practice-relevant trial of the week appears. In JAMA Ophthalmology, Zhang and colleagues randomized 160 infants under 1 year with congenital nasolacrimal duct obstruction to either in-office lacrimal duct probing or standardized lacrimal sac massage taught to parents. Resolution at 3 months was 86% with massage versus 84% with probing, a difference of 2.5 percentage points, comfortably within the pre-specified non-inferiority margin of -10 points, with no serious complications in either arm. The trade-off is speed, symptoms resolved in about 1 week with probing versus nearly 4 weeks with massage. So for the anxious parent of a 6-month-old with epiphora, structured massage is a legitimate first-line alternative to instrumentation, provided you set expectations that it takes weeks rather than days. Bear in mind, this was a single center in Guangzhou over 6 months, and the massage was standardized and supervised. Also in ophthalmology, a 1-year double-masked 3-arm trial of 225 children aged 6 to 14 compared a novel dual-sided composite defocus spectacle lens against a single-surface defocus lens and single-vision spectacles. Refractive progression was 0.22 diopters in the dual-sided group versus 0.83 with single vision and 0.45 with the single-surface lens, and axial elongation was 0.19 versus 0.42 millimeters against single vision. That works out to a 74% reduction in refractive progression and a 55% reduction in axial elongation relative to single vision lenses. Importantly, the axial length difference between the two defocus designs was not statistically significant, so the claim of superiority over existing defocus optics rests on refraction alone at 1 year. Rounding out the anterior segment, the American Journal of Ophthalmology published the largest contemporary series of uveitis glaucoma hyphema syndrome, 232 eyes over a decade. Posterior chamber lenses accounted for 92% of cases, 3/4 of those in the sulcus, and 2/3 of the sulcus lenses were single-piece designs that should never have been placed there. Median time from surgery to diagnosis was 4.8 years. Recurrence occurred in 46% of eyes, and although pressure and acuity improved modestly after intervention, persistent ocular hypertension remained in 59% of eyes, so this syndrome leaves a lasting glaucoma problem even when the mechanical cause is fixed. On the surgical side, a comparative study of 87 eyes undergoing Yamane intrascleral fixation found every formula tested, Hoffer Q, Holiday 1, SRK-T, T2, Barrett Universal 2, and EVO 2.0 produced a systematic hyperopic shift of roughly half to 3/4 of a diopter, and after constant optimization, no formula outperformed another. The implication is that variability in actual lens position, not formula choice, drives your refractive misses here, so consider targeting slight myopia. And briefly, a post-hoc analysis of the zoster eye disease study in JAMA Ophthalmology examined whether valacyclovir's effect varies over time. Recall the primary outcome was negative. This exploratory analysis found lower hazards during the treatment period and the first 6 months in particular, but none of these reached statistical significance. Read it as consistent with the existing 1-year recommendation, not as new evidence of benefit. If you only have time for one paper this week, make it the Congenital Nasolacrimal Duct Obstruction trial in JAMA Ophthalmology. It is a properly powered, randomized, non-inferiority comparison that lets you offer a non-invasive first-line option to a very common referral, and it will change conversations in general and pediatric clinics immediately. Here are the key takeaways from this week in ophthalmology. First, standardized parent-performed lacrimal sac massage matched probing for resolution at 3 months in infants under 1 year, but takes about 3 weeks longer to work. Second, an office pressure inside target does not exclude ongoing damage. A water drinking stress test flagged most of the fast progressors that tonometry missed. Third, repeat selective laser trabeculoplasty lasts roughly half as long as the first treatment, and advanced eyes with high medication burden warrant closer field monitoring. Fourth, in intermediate macular degeneration, ellipsoid zone integrity and hyperreflective foci are the strongest optical coherence tomography predictors of progression to atrophy. And in pachychoroid disease, shallow, irregular retinal pigment epithelium elevation was the sole feature preceding neovascularization. Fifth, faricimab maintained vision and produced complete polypoidal regression in about 60% of confirmed lesions, with most patients extended to 12 weeks or beyond, though in an uncontrolled single-arm trial. And finally, expect a hyperopic surprise after Yamane fixation, regardless of which formula you use. That's your roundup for this week in ophthalmology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one, in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.